I think we will get started. Before we jump into today's session, I wanted to do a land acknowledgement, and I want to be upfront. I have recently attended some sessions, and I realized that the land acknowledgement that I've been doing just wasn't quite enough. So I've gone into a little bit more in depth of a land acknowledgement. So bear with me. I think it's really important that we cover all of our bases when we do our land acknowledgement and include as much as we possibly can. So I'm going to go ahead and give this a shot, and I hope that everyone's okay with my little bit of a longer land acknowledgement, and then we'll jump into everything else. We would like to acknowledge that the land which we are gathered on today is the traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of Chippewas of Beausoleil, Rama, and Georgina Island First Nations, and more recently, the Mississauga of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and the Métis. These treaties and other agreements, including the One Dish, One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous people have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nation, Métis, and Inuit people. Now, I would like to welcome you and thank you so much for joining us today as we begin our second ECHO project series, Evidence-Based Palliative Symptom Assessment and Management. Today, we'll be discussing nausea and vomiting. Next slide there would be great. And then we would like to thank Health Canada for their financial contribution. The production of this presentation has been made possible through a financial contribution from Health Canada. The views expressed herein do not necessarily represent those of Health Canada. Today, our hosts are Laura Bates and Linda Meeks, both education facilitators with the North Simcoe Muskoka Hospice Palliative Care Network. And before I turn it over to them, I would just like to do a couple of housekeeping items. Sorry, ladies. We will be utilizing the chat today, so please feel free to enter any questions you may have in there if you don't have access to your microphone, as I will be monitoring that as well. And now the floor is all yours.
Thanks, Amanda. Welcome, everyone. We are Laura and Linda, as Amanda said. I am a registered nurse. I've been a nurse for approximately 10 years, with most of that focusing on palliative care. And Linda has been a nurse for many more years than that, and in a variety of settings, but mostly oncology and palliative care also.
Yeah, I hate to say how many, Laura. I think we're up to like 38 or something like that.
Now that you know a little bit about us, we'd love if you'd pop into the chat and just put your discipline and where you're checking in from today so we can see how far and wide across Canada we're reaching today. And Amanda can give us some ideas of who is here and where they are.
Okay, Laura, let's begin, shall we? So hello and welcome, everyone. Thank you for joining us today in our first session of our 8-session series on evidence-based palliative symptom management and assessment. Excellent palliative symptom assessment and ongoing management are based on the acuity, complexity, and variability of the person's condition. The use of standardized and evidence-based tools promote this excellence in practice.
Over the upcoming months, please join the North Simcoe Muskoka Hospice Palliative Care Network nurse consultants and education facilitators in our comprehensive review of the 8 Cancer Care Ontario symptom management algorithms. These symptoms include nausea and vomiting, loss of appetite, constipation and diarrhea, dyspnea, anxiety, delirium, depression, and fatigue. This review will assist you to identify and manage palliative symptoms, alleviate suffering, and improve the quality of life for your palliative patients or clients. These evidence-based guidelines are applicable to all palliative symptom assessments and management for all types of patients or clients with or without a diagnosis of cancer, and it can be used across all palliative settings. Whether you're an experienced hospice palliative provider or brand new to the area of nursing or healthcare, it is important to use standardized tools in order to enhance your practice and ensure that thorough assessment and management of the symptoms happens. These are all symptoms common to those who are receiving a palliative approach to care.
Nausea and vomiting are common and distressing symptoms in palliative care, affecting the majority of patients with cancer and other life-limiting illnesses. A systemic review of the prevalence of common symptoms in patients with varying life-limiting illnesses found that pain, breathlessness, and nausea and vomiting appear to be more common as death approaches. In patients admitted to specialist palliative care programs, nausea was reported by 36% of the patients at first contact with the service, 62% at 1 to 2 months before death, and 71% in the final week of life. In patients receiving palliative care, nausea and vomiting rarely occurs in isolation. They tend to cluster with other symptoms like fatigue, drowsiness, decreased appetite, and dyspnea. So for today, by the end of the session, participants will be able to explain the emetic pathway, discuss the etiologies of nausea and vomiting, review the clinical assessment and tools used, and identify the non-pharmacological and pharmacological treatments of nausea and vomiting. Clarification of the definitions of nausea, vomiting, and related phenomena is important for the correct assessment and treatment of these symptoms in patients receiving palliative care. Nausea is an entirely subjective experience defined as the sensation that immediately precedes vomiting. Patients state that they feel that they are about to vomit or describe the sensation as being queasy or sick to their stomach. Retching is the repetitive active contraction of the abdominal musculature generating the pressure gradient, which leads to the evacuation of the stomach contents. Retching may occur in isolation without the discharge of stomach contents, and this is referred to as the dry heaves. Vomiting is described as the actual ejection of stomach contents and is the result of contraction of the gut and thoraco-abdominal wall musculature. Regurgitation is the passive retrograde flow of esophageal contents into the mouth. Good evidence exists that various stimuli that affect nausea and vomiting come together in the area in the brain known as the vomiting or emetic center in the medulla. This center is not a discrete nucleus, but a complex array of neurons coordinated by a central pattern generator. Still, for our purpose today, it is useful to think of the final pathway that gives rise to the vomiting emetic pathway. So I'd just like to explain this to you so that we can continue on and realize the understanding of the emetic pathway for assessment and treatment. The vomit center receives input from 4 major areas: the GI tract, the chemoreceptor trigger zone, the vestibular apparatus, and the cerebral cortex. The center also has intrinsic chemoreceptors that can modulate, stimulate, and repress nausea. Each of these 4 areas responds to certain types of stimuli, modulated by specific neurotransmitters that bond to specific receptors. Understanding how these areas modulate nausea and vomiting helps us to tailor specific therapies for specific problems. As a primary source of toxic absorption in the gut, the effect of the GI tract on the vomit center is complex. Stimulation of the gut receptors and stretch receptors triggers nausea and vomiting via the vagal nerve afferents and afferent fibers associated with the sympathetic nervous system. The chemoreceptor trigger zone, or the CTZ, senses chemicals in the blood. The CTZ is particularly sensitive to increasing blood levels of potentially toxic substances. If a toxic substance is detected, nausea is experienced and the vomit reflex is initiated, hopefully before more toxic is absorbed. The brain detects an alien chemical, and if the concentration of the chemical is rapidly rising, this could constitute a threat to our health. So better to expel any residual substance in the stomach. Motion and body position are sensed through the vestibular apparatus. Motion sickness, such as car sickness, are mediated through this apparatus, as are inner ear diseases such as Meniere's disease. The vestibular apparatus serves as a sensor for certain toxins, such as alcohol, that can produce disequilibrium. Stimulation of the vestibular apparatus by alcohol may provide a survival advantage in keeping us from literally drinking ourselves to death. The cerebral cortex and associated structures in the limbic system modulate complex experiences such as taste, sight, and smell, as well as memory. And this is the mechanism that's involved in anticipatory nausea and emotion. Discrete neural pathways are less well understood. Receptors and neurotransmitters act like a lock and key system. Just as it takes the right key to open a certain lock, a neurotransmitter, which we will call the key, will only bind to a specific receptor site. Neurotransmitter receptors transmit the actions of the bound neurotransmitters, thus enabling cell-to-cell communication in the nervous system. Serotonin, acetylcholine, histamine, and substance P are major neurotransmitters in the gut. Chemoreceptors in the gut are major mediators of the toxic effect of certain chemotherapeutic agents, such as cisplatin, even when drugs are given intravenously via binding to 5-HT3 receptors. In addition to being a neurotransmitter that stimulates nausea, acetylcholine also increases gut motility and gut secretion. Histamine mediates transmission of nausea via the vagus nerve. Substance P binds neurokinin 1 receptors in the gut and directly into the vomit center in the brain. Two major transmitters are involved in the chemoreceptor trigger zone: dopamine acting on D2 receptors and serotonin acting on 5-HT3 receptors. Different toxin responses are mediated through different neurotransmitters. Opioid-related nausea appears to be most related to the stimulation of D2 receptors. Stimulus of the vestibular apparatus is mediated largely through histamine and acetylcholine receptors. Higher cortisol effects are important in the cerebral cortex and can be extremely powerful in stimulating nausea and vomiting. GABA is a neurotransmitter that blocks impulses between nerve cell in the cerebral cortex, and low levels may be linked to anxiety. Cannabinoid receptors are involved in a variety of processes, including appetite, pain sensation, mood, and memory. Common syndromes are involved with nausea and vomiting. Biochemical organ failure, chemotherapy, and drug-induced nausea and vomiting can result from fluid and electrolyte imbalances, organ failure, chemotherapy, and medication side effects. Gastric stasis, induced nausea and vomiting, can be a result of carcinoma of the stomach, ascites, opioid and anticholinergic drug side effects, and peptic ulcers. Gastrointestinal obstruction or irritation-related nausea and vomiting can be related to cancer, esophagitis, peptic ulcer, gastric distension, and compression, delayed gastric emptying, bowel obstruction, constipation, biliary obstruction, peritoneal disease, adhesions, chemotherapy and radiation, and infection and medications. Increased intracranial pressure that results in nausea and vomiting can be a result of cerebral edema, intracranial tumor or bleeding, and meningeal disease. Vestibular disturbances that trigger nausea and vomiting could be opioid-induced or due to cerebral metastases or motion sickness. Psychological induced nausea and vomiting may be due to fear, anxiety, and the anticipation of certain events.
Thanks, Linda. As you can see, nausea and vomiting is quite complex, and there isn't always a clear-cut answer as to why it is happening and what's going on. But now that we have a better understanding of the emetic pathway and the etiologies of nausea and vomiting, it will allow us to better assess nausea and vomiting. The assessment of nausea and vomiting is based on the understanding of the emetic pathway and the neurotransmitters involved, because the majority of antiemetic drugs are predominantly neurotransmitter blocking agents. They work at the receptor sites to block the receptors and prevent the message of nausea and vomiting to reach the brain or to go from the brain back into the body. Careful assessment will lead to a rational selection of an antiemetic agent to try. The first thing to do when you remember about assessing a symptom is to do so in the context of your patient's goals and values while taking their current PPS or palliative performance scale score into account. In order to do this, you need to know some other information about the patient's medical condition. This includes knowing their diagnosis and prognosis, any comorbidities that they may have, whether there is known or suspected metastasized disease, their current and previous medical treatment, such as chemotherapy, radiation, or surgery. And it is also important to know current medications, herbal supplements, over-the-counter medications, and vitamins. Finally, a thorough assessment of the physical systems, preferably done after the nausea has started so that it is recent, is important so that you know what the patient's change in baseline status is. Because nausea and vomiting are complex and can have multiple etiologies, a thorough history and physical is required to ensure that all possible causes of the nausea and vomiting are identified. There are a multitude of tools used to assess nausea and vomiting. In order to do it thoroughly, you must both quantify and qualify the characteristics of the symptom and its effect on your patient or client. Each of these tools listed on the slide can be used separately, but on their own do not provide a holistic view of the symptom and its effects on your patient. The Cancer Care Ontario symptom management algorithm combines all of these tools into one tool to guide your assessment and management of the nausea and vomiting. This is the first page of the Cancer Care algorithm, and as you can see, it is a step-by-step process that allows the practitioner to complete that comprehensive assessment that's required. The first step is to complete an ESAS, then assess the nausea and vomiting using the adapted assessment acronym, complete any further additional assessments, and then determine whether the patient or client is experiencing mild, moderate, or severe nausea. And we'll go into each of these steps in more detail next. Many who work in palliative care are familiar with the ESAS. It is a thorough and multifaceted assessment that allows you to look at the symptom profiles when you collect it over time. Typically, the client will complete the ESAS independently, but if not, the patient or client can be assisted by a caregiver or a healthcare professional in order to complete it. Each symptom is rated on a scale of 0 to 10 to measure the intensity of the symptom. It is a validated tool for both self and proxy reporting. It has also been translated into a multitude of languages, and there is a transcultural adaptation to be used in low and middle income countries. By assessing all symptoms and not just nausea and vomiting, the healthcare practitioner is better able to see if there's a correlation between the nausea and vomiting and any other symptoms that may be arising. The adapted assessment acronym is typically used when assessing pain. However, it does have a role in assessing other symptoms, including nausea and vomiting. It allows the practitioner to determine the meaning and impact of the nausea and vomiting on their patient and gives qualities of the symptom. So we'll go through each of these individually. Onset, when did the nausea begin? When did the vomiting begin, if there are both? If the patient is currently undergoing active treatment of any type, this will also allow you to determine whether it is acute emesis, delayed emesis, chronic emesis, or anticipatory. Acute emesis occurs within the first 24 hours of the treatment. Delayed emesis occurs in 24 to 48 hours after the treatment. Chronic lasts for more than 48 hours after treatment, and anticipatory happens before treatment in the anticipation of the treatment happening. Think when someone has treatment, they become nauseous, they vomit, they're anticipating their second treatment, and they may become nauseous before that treatment because they are assuming and guessing that they will become nauseous afterwards. Provoking and palliating. What brings on the nausea and or vomiting? Is it associated with a specific activity or the onset of a different symptom? What makes it worse? What makes it better? Quality. Can the patient describe how it feels? Is there nausea with or without vomiting? Is there vomiting without nausea beforehand? Is the nausea constant or intermittent? The severity comes back from our ESAS, where we've rated it on a scale of 0 to 10. ESAS, to be noted, is at this current moment, not in the past or an average. However, you can ask your patient, has the nausea been worse or better? What is its rating when it's at its worst and at its best? You can put this into the context of a specific time period, for example, the past week or since the symptoms began. Treatment. Are they using any medications or treatments to try and alleviate the nausea already? How are they using them? Are they using them around the clock or as needed? How effective are they? Are there any additional side effects from the treatments or medications that they're using for the nausea? Are they using any non-prescribed medications, such as over-the-counter medications or herbal and alternative medications to try and deal with their nausea and vomiting? Understanding is looking at what the impact is on the patient or client. Do they have any ideas about what they believe is causing the symptom? How is it affecting them and or their family or caregivers? Is their appetite or the amount that they are able to take in affected by the nausea and vomiting? And if so, how much and what are they able to eat or drink? What can they tolerate? What can't they tolerate? Are there specific types of foods or fluids that they can or cannot tolerate? Values looks at any other additional worries or concerns about the symptom that the patient and or their family may have. There's some other questions and assessments that need to be done in order to fully understand the possible causes of nausea and vomiting. In addition, these other important pieces of information are required to get the whole picture and determine, again, those possible causes. In addition to the previous background information and what you've learned through your assessment thus far, you should also think of and investigate the following. You want to know the date of your patient's last bowel movement, what its consistency was, and whether there have been changes in the pattern before or after the nausea or vomiting have started. You want to inquire about their weight before the start of the nausea and vomiting and whether there has been any weight loss because of it. If their oral intake of food or fluids has been affected by the nausea and vomiting, then you should complete a screening for malnutrition, and there's 2 listed there on your screen, which are also listed in the Cancer Care Ontario algorithm. You should complete a full physical assessment consisting of vital signs, an assessment of the oropharynx and mucous membranes, assess their hydration status, looking for signs of decreased urine output, dry mouth, or additional issues that may indicate dehydration, an assessment of the abdomen, and a rectal assessment to determine whether there possibly is fecal impaction. A neurological exam should be performed to rule out increased intracranial pressure or any other neurological etiologies, especially when nausea and vomiting is accompanied by headache. In the presence of moderate or severe nausea or vomiting, if there are signs and symptoms of dehydration or malnutrition, then additional blood work should be completed to assess blood count, electrolytes, urea, creatinine, glucose, and calcium. If a change in disease status is suspected, such as a change in the tumor load or new possible abdominal metastases, fecal impaction, or bowel obstruction, then consider X-rays and CT scans if clinically indicated and if they are within the patient's goals and values. If a patient is experiencing vomiting, then you need to assess the quality, frequency, quantity, and color of the emesis. Some other questions to think about while assessing your patient in order to help you think of potential causes of nausea and vomiting are these. Some of these causes would be considered palliative emergencies and warrant immediate investigation and treatment, again, in the context of the patient or client's wishes and goals of care. You want to know whether there's any additional symptoms such as anxiety or pain. Are they diabetic or newly diabetic and having a change in their blood sugar control? Is there signs and symptoms of a bowel obstruction or a GI bleed? Are there symptoms of increased intracranial pressure? Possibly symptoms of new or worsening infection? And are there signs and symptoms of new or worsening renal or hepatic dysfunction? These are all important things to keep in the back of your head as you're assessing your patient. So the Cancer Care Ontario algorithm classifies the severity of nausea into 3 categories: mild, moderate, and severe. Each classification is based on the rating of the symptom on the ESAS and some additional information. Mild nausea is rated as 1 to 3 out of 10. There may be loss of appetite, but there's no alteration in the eating habits and no dehydration. This would include people who are having anticipatory nausea. Moderate nausea is rated at 4 to 6 out of 10. There is decreased oral intake, but without significant weight loss, dehydration, or malnutrition. If they're receiving active treatment, they may not be able to eat or drink within 24 hours of that treatment. If their oral intake has been unchanged, there still may be evidence of dehydration for someone with moderate nausea. It is also classified as moderate nausea if a change in their treatment is not effective within 6 hours. Severe nausea is rated to a 7 to 10 out of 10. There is inadequate oral caloric or fluid intake and signs that may warrant possible hospitalization and further investigation. These signs would be evidence of dehydration or electrolyte imbalance if there is blood or coffee ground emesis or severe abdominal pain or headache. If a patient is weak, dizzy, incoherent, unresponsive, or showing other cognitive changes, that would also classify as a palliative emergency. There is extensive anecdotal evidence and scientific studies to support the use of non-pharmacological treatments for nausea. The first step in treating nausea and vomiting is to ensure that there is adequate control over all other symptoms and that there's treatment of any underlying causes that can be reversed. Every family and every person has their own tricks and tips on how to deal with nausea and vomiting. And some people may find that the use of relaxation techniques and complementary therapies such as aromatherapy or acupuncture are helpful. There's lots of other small tricks and tips that can be helpful. These include remaining upright or semi-reclined while eating and drinking and for a period of time afterwards, or something as simple as a light walk after a meal to help improve digestion. Some people find that altering their diet helps to alleviate their nausea by avoiding their trigger foods. There's also environmental considerations that may help with mitigating nausea and vomiting, such as the temperature of the room, the airflow, and exposure to noxious sights or smells. Every person that experiences nausea and vomiting will find some, all, or maybe none of these helpful, but they are worth trying because most of them have a minimal cost and are easy to try.
Okay, now I'm going to go over the pharmacological treatment for nausea and vomiting. And as we go, after you've finished your assessment, we've talked about the etiology of nausea and vomiting and the lock and key system, which refers to the neurotransmitters and the receptors, as well as the emetic pathway. Then you're going to understand why all that is important to put together in your history and your note-taking to recommend if you're a nurse for your scope of practice, or a physician or a nurse practitioner who can prescribe the proper pharmacological treatment. So it's important to choose the appropriate antiemetic based on the site through which the nausea and vomiting is most likely being mediated. You should choose the appropriate route of administration, consider the dosing schedule for your patient, and when possible, use only one antiemetic at a time and titrate to the maximum dose before considering switching or combining medications. So first we'll review prokinetic agents. These agents increase peristalsis, stimulate the cholinergic system in the gut wall. They block 5-HT3 receptors and activate 5-HT4 receptors, and blocking the dopaminergic pathway that slows gastric emptying. These agents are useful for the prevention of nausea and vomiting caused by chemotherapy, radiation, gastric reflux, and altered gastric emptying and peristalsis. They should not be used in patients who have complete bowel obstruction, GI hemorrhage, perforation, or immediately following surgery. These agents should be used with precaution in Parkinson's disease, high blood pressure, renal liver impairment, heart failure, and diabetes. Dopamine antagonists block D2 receptors in the chemoreceptor trigger zone, in addition to histaminic, muscarinic, serotonergic, and or alpha adrenergic receptors by increasing gastric motility and encourages gastric emptying. These agents are useful for complete bowel obstructions, opioid-induced nausea, chemotherapy, radiotherapy-induced nausea. These antagonists should not be used in elderly or demented patients or patients who have Parkinson's disease. Use with precaution in neutropenia, glaucoma, prostate hypertrophy, QT, interval prolongation, and extrapyramidal side effects. Antihistamines block H1 receptors in the vomiting center of the medulla, vestibular nucleus, and chemoreceptor trigger zone, and have antimuscarinic activity. They are useful for motion-related nausea or as a second-line agent for nausea related to brain involvement, which means vestibular disorders and increased intracranial pressure and bowel obstruction. They should not be used in elderly patients. They should not be used in conjunction with codeine, tramadol, tamoxifen, or patients that have seizures, epilepsy, and dementia. Precautions should be used with patients who have narrow angle glaucoma, prostatic hyperplasia, cardiovascular disease, hypertension, respiratory compromise, impaired hepatic function, and epilepsy. Serotonin 5-HT3 receptor antagonists block peripheral and central serotonin receptors, including those on the vagus nerve and chemoreceptor trigger zone. They're useful in both the prevention and treatment of chemotherapy and radiotherapy associated nausea or refractory nausea. They should not be used with drugs that prolong the QT interval or in severe hepatic impairment or in conjunction with tramadol. The precautions for these receptor antagonists is that they may cause constipation. Anticholinergics relax smooth muscle and reduce GI secretions by blocking muscarinic receptors. They're useful in terminal bowel obstructions, motion-induced nausea, and vestibular causes. They should not be used in the elderly and used with precaution in hepatic and renal impairment. Corticosteroids. The precise mechanism and method of action is unknown, but it's thought that they act centrally and may reduce nausea and vomiting due to an anti-inflammatory effect. Useful in nausea related to increased intracranial pressure, malignant bowel obstruction, and chemotherapy and radiotherapy-induced nausea. They should not be used in long-term palliative chemotherapy due to the risk of masking sepsis or fever. Use with precaution in patients who have diabetes, dementia, or a psychiatric history, and perioperatively. Cannabinoids. These agents act on the receptors in the brain to suppress nausea and vomiting pathways. They're useful for nausea and vomiting associated with chemotherapy and radiotherapy and should not be used in the elderly. Precautions are concurrent use with psychoactive drugs, sedatives, or any ethanol. Benzodiazepines enhance the effect of the neurotransmitter GABA. Useful for chemotherapy-induced vomiting and refractory anticipatory vomiting. Should not be used as an antiemetic unless as an adjuvant, and precaution is again in elderly patients. Octreotide reduces secretion of fluids by the intestine and pancreas, reduces GI motility, and causes vasoconstriction. Useful for malignant bowel obstruction, especially with high output vomiting that is unresponsive to other measures. Precautions include patients with diabetes, other endocrinopathies, elderly, and renal and hepatic impairment. It's hard to read all these after you've done so many. Okay, next slide, Laura. So this is just a graph, just to let you know, we will archive the presentation so that you can go back and have a look at these and have the information. So here you can see how antiemetics and the receptors work with the centers that we talked about in the emetic pathways. I'm not going to go through all of it, but you can see how it puts together all of the pieces that we've been going over so far today, including assessment, your emetic pathway, and the etiology of nausea and vomiting. And when you decide which area is affected, then you can choose the proper antiemetic. Laura and I have gone through the presentation and listed the common antiemetic doses to the drugs that were in the graph and the previous agents. And again, we won't go through all of this, but you can definitely find the information either here, or these are the drugs that are also listed in the Ontario Cancer Care algorithm for your mild, moderate, and severe nausea.
So you can see there's a variety of different medications in each drug class to allow you different ones to try depending on how your patient is presenting. And obviously check with pharmacy to ensure that there's no interactions between the drug that you want to try and any other medications or over-the-counter medications that your patients might be using. So we're going to do a little case study and learn about how to apply this algorithm in the assessment and management of nausea and vomiting. Now, this case study is interactive, so please feel free to unmute yourself and jump in with answers when we ask questions. Just remember to mute yourself again afterwards to avoid any background noise or feedback. And I unfortunately can't see the chat, but Amanda can. So if you're not able to speak and you have something to add to the chat, then go ahead and we will make sure that we are keeping an eye on the chat also. So I'm going to introduce you to our patient, and his name is Mr. T. He's a 67-year-old male diagnosed with lung cancer with metastatic disease to the liver. He is not currently undergoing any chemotherapy or radiation treatments. You've been called in to assess Mr. T because of reports of nausea and vomiting. Upon assessment, he has increased abdominal distension and ascites. He's reporting that over the last week, he's become increasingly nauseated. His appetite has been going down, and in the past 2 days, he's had 2 to 3 episodes of vomiting each of the days. He's now complaining about some fatigue that has increased and stating that the nausea and fatigue are impacting his ability to live his life. He's upset because the nausea and vomiting take away from the enjoyment he gets from eating his favorite foods. He has always raved every time you've seen him about his wife's cooking and how much it means that he is able to eat the food that she prepares for him. He has not gotten out of bed for 2 days now. I want you to think about what you've learned so far and think of some different additional information that we might need in order to finish our assessment, and then consult with his physician about managing the nausea and vomiting. So again, feel free to just unmute, shout out your answers, put it in the chat if you have to. What kinds of things do we need to know about Mr. T and his nausea and vomiting?
Rachel is saying what the triggers are.
Yeah, we want to know what provokes it.
Also, what has he tried and what the severity is.
Yeah,
Bowel movement.
exactly. We want to know about his bowel regime, his last bowel movement, his usual patterns.
What he's used in the past that has helped.
Yeah. Biggest thing we always need to know about what our patients are doing involves medication. So we want to know, is he taking his medication? What
And-
medication is he on?
And Sherry says, what helps? What makes it worse? Look at all meds being taken, like you said.
Yeah.
Do an ABD assessment.
Yes, do an abdominal.
Abdominal assessment, sorry.
ABD is medical shorthand.
Sometimes when you're reading, you just read exactly what's there.
We need to know what his goals of care are, what his current PPS is, what his usual PPS is. We know he hasn't gotten out of bed in 2 days. Is that normal for him or is that new? We might want to know, is there something going on with his disease? Is it progressing? Are there new mets? Also, we want to know, it says that he's not taking chemo or radiation, but has there been any other changes in his medications or in additional therapies that he might be seeking out? Okay, so the next slide, we're going to get some more answers about what is going on with Mr. T. So Mr. T has been prescribed routine lactulose because he's on opioids for the pain from his cancer. Unfortunately, he stopped taking it a week ago because he had an incidence of diarrhea. His last bowel movement was 4 days ago. He is passing gas, however. He also informs you that the nausea is worse when he attempts to eat or drink more than a few mouthfuls. The vomiting occurs within 30 minutes of attempting to eat more than a few mouthfuls. He also states in passing, however, that he feels full all the time, even when he hasn't eaten. There's no recent changes to his medications in the last 4 weeks, and he reports taking all medications as prescribed, except for the lactulose. Your last visit with Mr. T was 2 weeks ago, and his PPS was 50%. He's recently completed his DNR paperwork and has told you in the past that he wants to stay home and deal with things here until it's time to go to hospice. His spouse supports his decisions, but is concerned about his declining status. So let's work through the algorithm together and help us decide what the possible causes of Mr. T's nauseas might be. So our first step is an ESAS. We aren't given a specific ESAS score for nausea in this case study, but based on how he's described it and the information in the algorithm, we could assume that his nausea would be rated as moderate, or being a 4 to 6 out of 10. He has changes in his oral intake and his appetite. He has increased fatigue and possible evidence of dehydration. For the acronym, we know that the nausea started 2 weeks ago, or in the last 2 weeks at least, because he didn't report it when you last saw him. And we know the vomiting started 2 days ago. Eating and drinking makes it worse. And as far as you can tell from your assessment, nothing makes it better, but he also hasn't tried anything specific to alleviate all of it either. The quality is constant, but varying in intensity, generally increasing over the last week. We know this because he says that he feels full all the time. We know it gets worse with oral intake. He's not taking anything for the nausea or vomiting at this time, and he says that he's taking all of his other medications appropriately except for the lactulose. For the letter U, we know this is affecting him because he's told us. He told us that it's affecting his enjoyment of his favorite foods and keeping him from living his life. We know that he's a DNR and wants to stay home until going to hospice. We don't know whether he would want to go to hospital for further investigation or not. His spouse is concerned about his declining status, and we're not sure why yet. Is she worried it means he's closer to death or that his disease is progressing? Or is she worried about how she will care for him if he's bedbound and uncomfortable? We know that he's vomiting, but we know that there's no evidence of a GI bleed or bowel obstruction. He's described it as gastric contents and sometimes undigested food. No signs of blood or coffee ground emesis. It doesn't have a fecal smell. We need to remember that he has increased abdominal distension and ascites. We know that his bowels are not moving. He's on opioids and stopped taking his lactulose. His bowels haven't moved. He is passing gas. So we would assume it is not an obstruction. Could there be growing mets or additional mets? We know he has metastasized to the liver. It is possible that it has moved elsewhere or increased. We want to make sure we assess for dehydration and whether additional fluids would be warranted, such as IV hydration, and whether that would fall into his goals of care. Once you've gathered all of this information, we can start to make some decisions about how we're going to treat his nausea. Based on your scope of practice, you may be making suggestions to someone who can prescribe, or you may be prescribing it yourself. So how can Mr. T's nausea and vomiting be managed? First question is his bowel management. We've learned through the emetic pathway that slow gastric movement and possible obstruction or pressure receptors being triggered by being full of stool with constipation could be contributing to his nausea and vomiting. Anybody want to take a stab at what we could do to help manage his bowels? Go ahead, shout it out, put it in the chat.
I'm going to take a stab at saying this, bear with me. Metoclopramide, 10 milligram. Did I say that even close?
So that could be the answer to number 2, yes. But we want to make sure that he's not nauseous because his bowels are full of stool. So we want him taking that lactulose that he was prescribed, and we want him to take it regularly so that he's not getting constipated. We may need to adjust the dose if it's causing him diarrhea instead, or we may need to change it to a different bowel medication. There's lots of options in terms of laxatives, both liquid and pill, and whatever gets him to have regular, comfortable bowel movements will be the goal. We also want to ensure that we don't need to do something immediate, such as an enema or suppository. And we want to make sure that we're health teaching in regards to the use of bowel regimes to manage constipation while taking opioids. We want to make sure he understands that constipation is a constant issue with opioid use and that we need to stay on top of his bowels.
We have another comment here from Sherry saying Senna.
Yes, Senna would be a good alternative if the lactulose is quote unquote too powerful and causing him to have diarrhea instead. Number 2, what type of antiemetic would be appropriate? So you were on the right track, Amanda, with that.
Oh, that was from Nancy. That wasn't from me.
Oh, that was Nancy, sorry.
Yeah.
I was gonna say, I'm totally impressed, Amanda, because that's pretty bang on that chart.
I mean, yes, that was all me. No.
Yes.
So we definitely want to look at a prokinetic agent or a dopamine antagonist because both of those act in the GI system to help get things moving and we know that opioids slow that down. We can also assume, since the nausea is new, but the opioids are not, this is not opioid-induced nausea. Mr. T doesn't want to go to hospital. He's already expressed he wants to deal with things at home. So we are going to err on the side of caution and assume that it is not a bowel obstruction because there are no other signs or symptoms pointing to that. but it will be on our radar ongoing because of where his tumors are. Do you think he should be taking his antiemetic as needed or routinely throughout the day? Any guesses?
Nothing. Oh, routinely.
Routinely.
Nancy says routinely.
Yeah. He's expressed that there's always some nausea throughout the day, and it only gets worse when he's eating and drinking. Ultimately, we would love him to take the least amount of medication possible. So he may need to start on routine medications until his bowels have resolved, and we ensure that there's no other possible causes to his nausea and vomiting. Other medications we might find helpful in this situation. Any guesses from anybody? We talked about benzodiazepines. We talked about
Motility
steroids.
agent. Rachel says a motility agent.
Yep. Something like octreotide may help. For Mr. T, the doctor's also thinking of prescribing corticosteroids because he's got tumors in his liver. We know that when there is increased pressure in the abdomen, it can cause nausea. So it's possible that the tumors on his liver are pressing onto the GI tract and causing some of the nausea. Other measures that might be helpful. Is there any guesses about anything else we might be able to do to help alleviate his nausea and vomiting?
Carolyn says smaller meals.
Definitely smaller meals. We don't want him to overeat and cause the nausea to get worse.
More frequent meals.
Yeah. If Mr. T was in agreement, you could offer a paracentesis for the ascites if it was clinically warranted. Could also do further diagnostic imaging to determine whether there's additional metastases or growing mets, and whether there was a mechanical obstruction of the bowel because of those. Additionally, if the vomiting had been going on longer, you may want to look at blood work for hypercalcemia or electrolyte imbalances. So again, this is showing that the causes of nausea and vomiting are widespread, and you have to take into account each of the possibilities before you pick an antiemetic. Because if you were to pick something like an antihistamine, it probably wouldn't work because Mr. T is not showing signs that it is that pathway that is being affected. Any guesses as to what the clinical diagnosis and cause of the nausea and vomiting might be based on what we've learned about Mr. T? Thinking about his bowels, hint, hint.
Disease progression.
Yep, definitely disease progression. We know there's mets in the abdomen.
And in the liver.
Yeah.
Colon cancer.
It could be that it's spreading. Yep. It could simply be he's constipated and on top of the slow gastric emptying from his opioids. So we get our recommendations. Mr. T's prescribed an antiemetic and a steroid, and you go back to see him a week later. Mr. T is ecstatic when you return, stating he's returned to his baseline, and that concurs with your assessment. He informs you he's able to enjoy his favorite foods again. He reports no vomiting over the past week and states he only feels nausea once or twice when he eats too quickly, but it passes and doesn't require additional doses of medication. When you're leaving your visit with him, he says to you, "I pity the fool. I pity the fool who doesn't deal with the nausea and vomiting." So on the last slide, again, as Linda said, our presentation will be archived. So these are the resources that we used in addition to the cancer care algorithm. And we'd like to open it up to any questions or comments that anybody has.
Sherry says, awesome, thank you. Now she's on to the next meeting.
Awesome.
I just have a comment, Laura.
Okay.
I have to say that the review of the emetic pathway and the receptors and the neurotransmitters was like a whole new learning experience all over again.
It was like going back to pathophysiology 101. That's for sure.
Because we take all this for granted and without really sometimes thinking the depth of what our assessment actually means and how to go from there and reason through.
For sure,
Yeah.
for sure. It's easy to take advantage of the fact that this all works normally on a good day without us even thinking about it.
Mary Lou would like to know, when would you suggest NPO? What about someone who has fecal emesis and may need a vented G-tube?
It would obviously depend on what their goals of care are. If they have decided that they only want symptom management and don't want any sort of intervention in terms of treatment, then they may not even want a G-tube, whether we as clinicians would think that that was the next step or not. Working in a residential hospice, I've often had patients who have a complete bowel obstruction and only want symptom management in terms of medications. And that may mean that you also add in some sedation, depending on what their goals are and how awake they want to be and how comfortable or uncomfortable they are okay with being. NPO is definitely warranted if they aren't managing any sort of oral intake or if that is aggravating things. And NPO is definitely the first line of defense with any sort of obstruction, because what's going in can't get through and you don't want to keep adding to that.
Yeah. So I guess if someone has fecal emesis, then that's an automatic NPO. And then, like you said, question the G-tube, but then you have to figure out, why is this person having fecal emesis before you start prescribing medications, right?
So Mary Lou just wanted to comment again. Let's say they want a G-tube and are in hospice, no sedation is wanted.
As a nurse, I'm not sure where I would want to see that going. I know in the residential hospices that I'm familiar with, things like the insertion of a G-tube or even the presence of a G-tube are not typical. Typically, if somebody wanted that level of intervention, they'd end up in hospital. So I personally can't answer that question, but I could gladly, if you wanted to get in touch with me, I can make sure my email is in the chat, and then I can, if you want to email me that question, I can do some research and get back to you later on that.
And we have Rachel saying, I think it just validates the need for a thorough assessment.
Definitely. If you simply took the nausea and vomiting at face value and prescribed a medication that was contraindicated in an obstruction, for example, and that was the cause of the nausea, then you'd be doing more harm than good. I'm just putting my email in the chat.
I did that for you, Laura.
Oh,
Thanks,
okay.
Amanda. You're way faster than I am.
Laura, can you just go back to the slide that's got the actual algorithm on it?
Yeah. Give me a second to flip back through.
I just want to reiterate that if you use this algorithm tool, it actually lays everything out for you so simply that Laura and I have already gone through, without, of course, all of the in-depth background. But it really is a fantastic tool for assessment and then follow through based on what your findings are. So if you're having difficulty or just in your everyday practice, we use these at the network in our everyday practice. And I know some of the hospices have them as part of their everyday practice as well. So
So the page of the algorithm that we did not specifically show maps out the suggested pharmacological treatments for each of the possible causes of nausea and vomiting, and whether it's mild, moderate, or severe. And it does, let me just find it here. It does discuss whether, if it's an obstruction, what the additional measures would be.
And I've just put in the chat there a link to our virtual resource package where they can find the algorithm as well.
Perfect. Did we get through everybody's questions, Amanda?
Yep, that seems to be everything. There's a lot of thanks, guys. Great info. Thank you so much.
Great. And I think that brings us
Perfect.
just
Thank
about to the end of our time.
Thank you, everyone.
That's great. Thank you so much. That was a great presentation and lots of wonderful information included.
Thanks,
Thank you.
Amanda.
Have a good day, everyone.
Bye.
Take care, everybody.